The next group before us is the Ontario Nurses Association, Beverly Mathers and Lawrence Walter, and the clerk is coming around with a written submission. Good afternoon. Welcome.
Thank you.
Hi. As you probably heard, you have 10 minutes for your presentation, followed by 5 minutes of questioning. And this round question will be coming from the official opposition party. You may begin any time. When you begin, can you please identify yourself for the purpose of the answer? Thank you.
Thank you very much. Good afternoon. I'm Beverly Mathers. I'm a registered nurse and manager of negotiations at the Ontario Nurses Association, or ONA, as I'll refer to us throughout the presentation. With me today is Lawrence Walter, ONA's Government Relations Officer, and we also have some ONA RNs behind us. ONA is Canada's largest nursing union, representing 60,000 registered nurses and allied health professionals, as well as more than 14,000 nursing student affiliates who provide quality patient care each and every day across the healthcare sector. ONA believes that a strong public healthcare system is essential for Ontario's economic well-being. Quality healthcare is also a precursor for a healthy Ontario. RNs provide a continuous presence at the patient's bedside, and those same RNs play a major role in healthy outcomes for patients. The invaluable skill set of RNs has not been adequately recognized and utilized to achieve our common vision of quality patient care in Ontario. Instead, funding models are driving decisions to eliminate and erode RN positions. These decisions are based on balancing budgets, not at all based on the clinical needs of our patients. The government's calculation of risk fails to consider that every elimination of an RN position is the equivalent loss of 2,000 hours of annual RN care for our patients. In Ontario, the ratio of RNs to the population is the second lowest in all of Canada. RN has only 714 RNs per 100,000 compared to 336 RNs for 100,000 people in the rest of Canada. This difference creates a significant gap in RN care for Ontario patients. In fact, it means we need a funded plan of action to hire more than 16,500 registered nurses in Ontario just to keep up with the rest of the country. This afternoon, I want to focus my remarks on the dire need in this budget to fund more RNs in our hospitals, community sector, and in our long-term care homes. Our hospitals are struggling to keep up with the cost inflation and population growth in the context of 4 consecutive years of frozen base operating funding. In response, hospitals are adopting short-sighted and risky measures, including the elimination of RN positions, not replacing RN positions when they become vacant, and substituting RN positions with less qualified staff. There is extensive and compelling literature on the relationship between higher RN staffing levels in hospitals and improved patient outcomes. Conversely, decreasing RN staffing has a negative impact on patient health outcomes. This growing body of evidence clearly shows that patient care is most safely delivered when there are enough RN hours of care. Any costs associated with RN care must be balanced against the cost savings of preventing adverse patient events and complications. How is it that study after study demonstrates cost savings and improved health care outcomes with RN care, while Ontario continues to eliminate the very RN positions that benefit the health of Ontarians? RN care in Ontario hospitals is being seriously eroded. In 2015, we lost 775 RN positions. Since January 1st, 2012, more than 2,500 RN positions have been deleted, which means that nearly 5 million hours of RN care have been eliminated from our communities during this period of time. completely ignoring the evidence linking RN care to improve patient outcomes and cost savings to our healthcare system. Hospitals are reporting deficits and hospitals are citing the funding model as the reason. The funding gap to balance hospital budgets will continue to worsen in 2016 and 2017 unless immediate steps are taken to restore base operating funding. The Ontario Hospital Association is now speaking out after 4 years without a funding increase. Hospitals are at a critical turning point, stating it's time for the government to increase hospital funding in the upcoming budget. ONA agrees. Already this year alone, we've had in 1 month more than 300 positions being announced to be eliminated in our hospitals. 2 recent examples show that hospitals are making wrong decisions based on the research evidence linking RN care to improve patient outcomes and cost savings. For instance, Windsor Regional Hospital has announced a $200 million deficit and has responded with a significant elimination of 800 positions being replaced by non-RN positions. In total, 169 RN positions will be eliminated. In the Waterloo-Wellington region, the Grand River Hospital in Kitchener has also announced a $10 million deficit and plans to eliminate at least 38 RN positions. Both hospitals cite a funding model that is insufficient to cover the costs of providing skilled RN care. ONA challenges the government to no longer remain silent on the continuous deletion of RN positions. More hospitals are announcing the elimination of RN positions each week. 28 positions eliminated in Northumberland Hills Hospital in Cobourg, 17 RN positions at Blue Water Health in Sarnia, and 8 positions in St. Thomas Elgin. Today, announcements at Mount Sinai and the University Health Network. Now is the time to restore hospital-based operating funding. Along with increasing base funding for hospital, ONA is calling for an immediate moratorium on further cuts to the invaluable cost-effective RN care. Third, we are calling for funding and development of a multi-year RN human resource plan for implementation and tracking by local health integration networks targeted to reduce the significant gap in RN to population ratios between Ontario and the rest of Canada. Additionally, we are asking that this nursing human resource plan be incorporated into the government's Patient First Action Plan for healthcare in Ontario. Fourth, we are calling for the government to move toward a fully integrated public home care system that integrates both the delivery of home care services as well as care coordination. This will eliminate the duplication of management contracts and will provide cost savings from the elimination of profit from our home care system. Fifth, we are calling for the funding and enforcement of a staffing standard to meet the increased care requirements of our residents in long-term care homes. ONA is calling on the government to implement a funded, regulated minimum staffing standard of an average of 4 worked hours of nursing and personal care per resident day, including 0.78 RN hours per resident per day, which will address the increasing resident acuity, resident-to-resident homicide and violence, and RN staffing recommendations for quality care that is contained in research literature. Finally, ONA is calling on the government to fund a health care action plan for workplace violence prevention that mandates key standards in hospitals and LHINs and government accountability agreements. These standards must be mandated to include RN safe staffing levels, appropriate security funding, use of best practices for training, accessible panic alarms linked to security, and electronic and visual alert systems for flagging potentially violent patients. Nurses know the evidence for RN care is compelling for improved patient outcomes, and it means system costs overall. ONA ONA and our nurses know that additional funding will be necessary to ensure quality patient care. The government must take action now and show leadership to fund RN care that our patients need and deserve. The government must break the silence. Our patients' health depends on it. Thank you.
Perfect timing. I'm going to turn to the opposition party. Ms. Monroe, you're going to begin this round of questioning.
Thank you very much. I appreciate the underlying theme of your message in terms of how critical the information is and the things that you're dealing with. And I think as a general comment, I would simply say that it serves to give further meaning to the crisis that we recognize is in healthcare. On your, in the document that you provided, on page 9, the diagram there about when RN workloads rise, Ontario patients suffer. In this, you talk about the increase in complications, and you mentioned the return to the hospital because of those kinds of things. But I wondered, there's the next one is the 7% increase in mortality. Were there inquests? Do we have numbers? Is there any way to sort of put that into specific context?
I do not believe there have been any recent coroner's inquests into deaths in hospital or in recent patient discharge. This study that we cite by Linda Aiken was actually a study that looked at some Canadian evidence, some Ontario evidence, as well as worldwide, and the determination showed that that patient care suffered as RN workloads increased, and that in fact that patient mortality increased by 7% for every one patient added to a nurse's workload over 7 patients on average.
Right.
Just further to that then, with the, how many caseloads are there in Ontario that are over 1 extra patient or over 2, and then by extension, how many dead in Ontario?
Well, I can't speak to the death rate because there, to my knowledge, that we don't have those statistics, and I would suggest to you the statistics that are out there are probably incomplete. But our nurses report to us daily that their workloads increase. As you can see, these workloads where there are significant RN workload or layoffs, that means our nurses are experiencing more patients assigned to them on a daily basis. We hear our nurses tell us that on an inpatient surgical unit, they could have anywhere from 8 to 10 patients assigned to them, more on the evening shift when they're immediately in their post-operative period, and more so yet assigned on the night shift.
Does the hospital have any flexibility in this in terms of when they make the decisions? I presume they make the decisions to reduce staff. Do they have any funding flexibility?
The hospitals have the ability to make decisions around the skill mix they keep in hospital. I think the struggle with it is yes, in fact, they do have flexibility. I think the challenge at the moment is that after the operating budgets have been fixed for as long as they have, the flexibility is being more and more limited as other factors around them rises, like the cost of hydro, replacement of equipment, those kinds of things. I think the decision making is becoming harder.
Mm-hmm, mm-hmm. Appreciate the comments. Anything else you want to add?
Maybe just further to flexibility, I understand the funding for hospitals gone from a global budget approach to an activity-based approach. Does that mean less flexibility for a hospital administrator or a nursing supervisor?
Do you want to answer?
Sure. Yeah, it depends on the actual funding, but for when funding is part of a procedure-based funding, then there is less flexibility because the funding is specifically for specific procedures. So that does leave, global funding generally leaves more flexibility than funding for a specific purpose, like surgery, hips and knees, that sort of procedure.
So we're essentially, there's no global funding,
No, there still is about a 30% component of
30%?
global
Okay.
funding.
60,000 members, how many members work in hospitals?
50,000 work in the hospital sector,
50,000 or so?
in that range, 45 to 50.
Okay, I'm going to stop here. Thank you for your time, and thank you for your written submission. Thank you.
Thank you.